morning and welcome to DeBakey Cardiovascular Grand Rounds at Houston Methodist Hospital. We're about to hear a very exciting presentation from Dr. Geoffrey Barnes. I am your host, John Cooke. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist Hospital. And the discussion today is sure to generate some questions and dialogue. So before we begin, I wanted to remind you that you can join by web. Go to pollev.com, that's pollev.com, enter DeBakey, and then you can respond to our activity. Or you can join us by text. Text DeBakey to 37607, and then text in your message, and I'll read the questions to our guest, Dr. Geoffrey Barnes, who's joining us today from University of Michigan. Welcome, Jeff. I'm going to...
thank you so much for having me.
Absolutely. Let me just give you a short introduction. Jeff is assistant professor at the Frankel Cardiovascular Center and at the Institute for Healthcare Policy and Innovation at University of Michigan, where he did his medical school, his internal medicine and residency, chief residency at University of Michigan before he went on to get his training in cardiology and vascular medicine. So he's particularly trained in vascular medicine and with an interest in thrombosis. His research and clinical practice focuses that care of patients with deep venous thrombosis and complications from that, and anticoagulation therapy. He has research funding from National Heart, Lung, Blood Institute and the Agency for Healthcare Research and Quality. And he serves as co-director of the Michigan Anticoagulation Quality Improvement Initiative. He has leadership roles in thrombosis and anticoagulation care of these patients at the American Heart Association, American College of Cardiology, Society for Vascular Medicine, and the International Society on Thrombosis and Hemostasis. Jeff, it's great to have you here this morning to hear what you have to say about the treatment of patients with thrombosis, building systems to improve care delivery. Thanks so much.
Well, thanks again for having me, and I'm really honored to be invited to speak with you all this morning. I do wish I could be there in person. Houston is a special place for me. I have many friends and family there, but given the pandemic, we'll have to do this virtually. As was just mentioned by Dr. Cooke, I'm excited to talk about antithrombotic medication management and some of the ways we've been thinking about designing our systems to improve our care delivery. As was mentioned, I do have some disclosures. They largely relate to companies that either make anticoagulants, reversals for anticoagulant medications, or other tools that try to improve anticoagulation care delivery. In about the next 45 minutes or so, my goal is really to tell you three different stories. And these stories center on a system redesign for improving care, broadening the traditional role of what we think of in an anticoagulation clinic, and then a story around the mantra, work smarter, not harder. And so I'm going to step through each one of these here during the talk today. Let's start with this first story of system redesign and the way we redesigned a care delivery model to improve care for some of our patients. But to do that, I need to lay a little bit of groundwork, make sure we're all talking about the same types of terms and have some background information. Antithrombotic medications, and when I say that, what I mean is both anticoagulants and antiplatelet medications. These are actually the #1 cause of adverse drug events for patients presenting to the emergency department. In fact, if you look here on the right-hand side of the screen, you can see some data that's almost a decade old now, but that was published in JAMA showing the #1 causes for ED visits for adverse drug events. Far and away, the leading cause of adverse drug events in the emergency department was an anticoagulant, warfarin, followed closely by antiplatelet medications, clopidogrel and aspirin, and then a little farther down the line, another anticoagulant, rivaroxaban. Now, I'm pretty certain if we were to update this data here in 2020, 2021, we would see a similar pattern, but we would see some of our newer direct oral anticoagulants, rivaroxaban and apixaban, climbing up the list just because they're so commonly used in clinical practice today. Now, this is of particular concern for patients who are undergoing surgical procedures, because while these medicines are highly effective at preventing clots from forming, in the setting of a surgical procedure, they also put the patient at risk for bleeding. And of course, that's a balancing act we're always trying to figure out how to most safely manage. In fact, one particular question is particularly challenging for many clinicians and patients, which is, when should I stop an antithrombotic medication before surgery? And the truth is, it really depends on the medicine, and we're going to see that in just a second. But sometimes there's actually a second question that gets built in, which is, if I stop my antithrombotic medicine, do I need to close the gap? Do I need to somehow bridge them with another shorter acting agent so that they're not exposed to too much thrombosis risk? This is actually a really common situation. If we just look at one indication for patients taking antithrombotic medications, that's atrial fibrillation, and we look to see how many of those patients are going to have a surgical procedure, it's more than 500,000 patients every year in the United States. So this is an extremely common situation that patients and their clinicians are encountering. Now, I mentioned that there are different ways that we manage these medicines before surgical procedures. I'm going to show you just two. Let's focus on the anticoagulants here. On the left side of the screen, you see sort of a schematic for how we conceptualize warfarin management before a surgical procedure. Warfarin, of course, we've been using for decades. Many of us are pretty comfortable and familiar with how it's used. And in fact, one of the hallmark features is this really long effective half-life, meaning that you need to stop warfarin 5 days before a surgical procedure so that the anticoagulant effect can wear out of a patient's system before they go and have their surgical procedure. Now, of course, once they have their surgery and you restart warfarin, it's going to take a number of days before that patient gets back up into the therapeutic range. In this case, we're showing that as about 5 days, but we've actually published some work to say in certain situations, it could be as long as 7, 10, or maybe even 14 days before a patient is fully therapeutic. So that creates quite a wide gap, anywhere from 1 to 2, maybe even more weeks, that a patient is not fully protected against thrombotic complications. Now, that's very different than the patient who's taking a direct oral anticoagulant, something like rivaroxaban, apixaban, dabigatran, or edoxaban. These drugs have much shorter half-lives. In fact, when you stop that drug, it's usually out of a patient's system within 24 to 48 hours, very different than what we see with warfarin. Perhaps even more distinguishing from warfarin is the fact that once you take the pill, the patient is fully anticoagulated within a matter of hours, probably 2, 3, 4 hours. Very different than what we see with warfarin, where it's measured on a time course of days. And so understanding the different pharmacokinetics of these drugs really impacts how we think about managing them before and after surgery. Now, of course, we talked about for warfarin how many patients have this multi-day, maybe even multi-week gap where they're not protected from their thrombotic underlying disease state. And so ideally, you could find some sort of a bridging agent that could just cover whatever degree of anticoagulation is needed to bring that patient back up to the therapeutic range. This is sort of the goal that we would ideally shoot for. However, what we would like and what we actually have are often two different things. And in fact, what we most commonly use, low molecular weight heparin, or even admitting somebody for unfractionated heparin, when we bring them into the hospital, we're giving them sort of a full dose of anticoagulation with that heparin, which means that sits on top of whatever remaining or building up effect of warfarin is there. So in some cases, these patients are actually at increased antithrombotic levels, and therefore at potentially higher risk for bleeding. You can see that on this bottom graph by the blue and the red bars stacking on top of one another. So because of this question, this is actually part of the reason that the BRIDGE trial was run more than a half decade ago now. This was a trial of patients who were taking warfarin therapy for atrial fibrillation, venous thrombosis, something like that, and they needed to undergo a surgical procedure where the warfarin had to be stopped. These patients were all randomized early on, and warfarin was stopped 5 days before the surgical procedure. Now, half of them were randomized to get that bridging low molecular weight heparin drug. In this case, they used dalteparin, but you could easily replace that with something like enoxaparin if that's what's used at your center. The other half are randomized to receive placebo, so no bridging anticoagulant. They got that for a couple days before surgery. They went ahead and had their procedure on study day 0. Now, perhaps the most interesting and innovative part of this study is what happened afterwards. For the patients who had been randomized to get the bridging low molecular weight heparin, they could restart that agent as soon as the night after surgery, or delay that all the way up until 3 days after surgery based on the bleeding risk associated with the procedure. So if the concern was the patient was at high risk for bleeding, wait 2 or maybe even 3 days before they started the bridging agent to try and avoid that post-operative bleeding complication. Now, the placebo patients similarly started, but of course that had no anticoagulant effect for them. And patients were followed all the way out until 30 days after their surgical procedure. The main high-level outcomes of this study, where they randomized almost 2,000 patients, are seen here. And I'm going to highlight a couple elements. First, I want you to look at the adverse thromboembolic risks, the arterial thromboembolism of stroke and transient ischemic attack. In total, across nearly 2,000 patients, there were 7 thrombotic events. We are talking about extremely low event rates, less than 0.5%. So really, there's not a very high risk of thromboembolism for these patients. And in fact, this was a statistically non-inferior finding between these two. That's what that first p-value with the star there represents. Now, that's in contrast to the safety events, the bleeding events that you see. Major bleeding here was much more common. It was about 1 to 1.5% in the placebo group, but it was over 3% in the patients who received bridging. That led to a number needed to harm of 50. Perhaps even more concerning is the minor bleeding, things that did not require surgical intervention, did not require transfusion, but did lead to the patient contacting their healthcare provider, maybe coming in for evaluation, certainly things that are concerning to the patient. These were extremely common, 12% in the placebo group, almost 21% in the bridging group. Nearly 1 in 5 patients had a minor bleeding event. Now, the difference between those was a number needed to harm of 11. Or taken together, what I say is that for about every 10 patients you would choose to bridge, one of them is going to have some sort of a bleeding complication, but you're going to see no difference in thromboembolism. So I think from this study, the big take home is that the vast majority of patients who are on warfarin do not need to have any bridging when they have a surgical procedure. And in fact, that probably even applies to patients with prior stroke or TIA. 15% of this total study cohort had prior stroke or TIA, and still we see these extremely low adverse event rates as far as stroke and transient ischemic attack are concerned. Now, we were curious to know, after this study was published, how well did clinicians know about this and what were they thinking about applying this to their patients? So we performed a survey that would help us understand the current state of knowledge. And to do that, we surveyed cardiologists, primary care clinicians, and GI docs. And we did that using a specific scenario or set of scenarios of a patient who was on warfarin for atrial fibrillation who needed to undergo a colonoscopy for which. Now, in these scenarios, we varied the stroke risk. Because the bridge trial used the CHAD score, we followed that same model, and we gave these patients a CHAD score of 1, 3, or 5, what you would consider low, intermediate, or high risk for stroke. And we also varied whether or not that patient had a history of stroke in there as well, so we could try and identify what factors were leading clinicians to make their clinical decisions. Here is some really interesting information. On the left side of the screen, we saw that patients who were at low risk for stroke, a CHADS of 1 with no prior stroke, nearly all the clinicians agreed you would not bridge that patient. And all the way to the right side of the screen, you see for our highest risk patients, those with a CHADS of 5, what would probably be seen as a CHADS VASC of 7 or 8 now, who had a prior stroke, nearly everyone agreed we should probably be bridging those folks, 75 to 95% of folks. But these middle 2 columns are where things get really interesting. First off, both of these columns represented patients with similar stroke risk. One of them had CHADS 3 with no prior stroke on the left. the other CHADS 3 with a prior stroke on the right. And you can see the dramatic difference. A history of stroke was a big driving risk factor for why clinicians would choose to bridge a patient. But even within them, you see a ton of variation, a lot of heterogeneity based on the background that the clinician has, their training. Cardiologists were the least likely to choose bridging, that's the blue bar, compared to the gastroenterologists in orange, the internists, the general internists in gray, and the family med docs in yellow. And so this wide variation in background as the predictor of what you would choose is something that we really honed in on. So we said, gosh, is this a sign that there may need to be some better education of providers about the evidence for and against stroke prevention in the perioperative period? Now, we asked them, do you get enough support from your institution to help you make this decision? And what we found is the GI docs, the proceduralists, and the primary care docs said, you know what? No, we need some better support. More than half of them said we need more help from our institution. And when we asked whether the anticoagulation clinic could help with this, overwhelmingly people said, yes, we would love to have that support. And so that led us to this study that we did, which really used this conceptual model that for many patients undergoing a surgical procedure, they're not really sure who they should be talking to figure out how to manage these antithrombotic medications. Should they talk to their surgeon or proceduralist? Should they be interacting with the anticoagulation clinic? Maybe it's a pre-op clinic or anesthesiologist. Maybe it's another clinician like a cardiologist or primary care doc. And furthermore, those clinicians are not routinely talking to one another either. And in fact, there's a lot of finger pointing, you're responsible, no, you're responsible. And there's just a lot of confusion, and the patient is often left perplexed as to exactly what to do. And we said, there's got to be a better way. There's got to be a way we could redesign the flow here so that everyone is working together. There's a clear pathway for decision-making so that the patient knows exactly what they should do and who they should interact with. And so that's really what led us off on this project. And so our goal was to understand the current state of periprocedural anticoagulation using elective GI endoscopy as a common exemplar for this particular clinical scenario. We then wanted to develop an implementation plan on how we would redesign the management for patients, and then to implement that at our health center. So we got some baseline metrics, and what we found was that we had about 6 cases every day where a patient was undergoing elective outpatient GI endoscopy while also being on an antithrombotic medication. And when we called patients to ask them about their satisfaction with the care coordination, 20% or 1 in 5 said they were dissatisfied with how that care coordination happened. They did not feel like it was well coordinated and well communicated. When we actually asked the nurses in the endoscopy unit to keep track of how well patients had managed their medications, we found that 17%, again, almost 1 in 5 patients presented having mismanaged their medication. And in fact, 6% of the time, 1 in 20, we had to cancel the case outright because it was deemed not safe to do. Maybe we were planning to do a large biopsy and the patient hadn't stopped warfarin, and so we just didn't think it was safe to proceed. And so with that, we said, let's put together our multidisciplinary team. So we brought together clinicians, physicians with lots of different backgrounds and invested interests. We brought together pharmacists from our anticoagulation clinic, a number of different nurses representing different stages in the process. We even had some schedulers to help understand the administrative piece of this. We brought a couple patients on the team, and of course, some IT folks, because every solution these days seems to involve the electronic medical record. And what we did, we spent about 4 months really trying to understand the current workflow. What's the current state of work as far as who does what decisions are made, where people pass information. And we developed this really nice workflow map. I've taken the liberty of just summarizing the high-level points for you here. We identified essentially 5 key steps. The first is that somebody has to order the endoscopy, right? And that's usually done by one of our clinicians, either a primary care doc or a GI specialist. But sometimes that's actually done by an outside physician who's still asking for that to be done at our institution. So we have these outside referrals coming in. We then said, well, who figures out that the patient is actually taking a blood thinner, an antithrombotic? And lo and behold, it was the GI scheduler. The GI scheduler would call the patient and go through a list of things. Remember, you need to have a driver. Remember, you need to do this. And then they would say, do you take any blood thinning medicines? And if the patient said yes, the GI scheduler would literally tell the patient, you need to ask your doctor who manages your blood thinner how you should manage it before surgery. So then in step 3, we put all of the onus on the patient to coordinate that care and figure out who was going to give them instructions on what to do. Was that a primary care doc, a cardiologist, somebody else? Who knows? Now, we all know patients often can feel very overwhelmed in this situation. They may not know which of their pills is an anticoagulant or which clinician is responsible for that, how to get a hold of them. This is clearly a system designed for failure. Then somebody had to give an instruction to the patient on what to do. And there was no routine way that was being done. And because of that, when we then went to do a check on how the patient managed their medicine before surgery, again, there wasn't a routine way to verify that what the patient had done matched what we clinically thought was most appropriate. So we identified 2 key elements here, 2 major problems. First is who was identifying that the patient was on a blood thinner. We didn't like the fact that it was a non-medically trained person. Second, we asked who was responsible for communicating and decision-making. That was too much responsibility on the patient and not enough of a systematic approach. So we said, we can solve this problem. So we thought about how to reorganize this. And we said, we need to be accountable to our patients so that we own the coordination as a health system, not the patient. We wanted our decision-making to be transparent so that everyone could see what was happening. And we wanted it to be consistent and evidence-based, with a robust practice that handled not just our internal orders, but also the external referrals we're getting. And of course, the more we can automate a process rather than relying on humans to remember this, the better. And so with that, we redesigned this system to say, okay, now when we order a GI endoscopy, the electronic medical record is going to identify that the person takes a blood thinner, and it's going to trigger an alert. And that alert is going to help get the patient to our anticoagulation clinic, where they're now going to use some institutional guidelines to manage this medication and tell the patient when they should start, when they should stop, things like that. They're then going to use some pre-set templates to provide key instructions to the patients. So the patients know on Monday I take my pills, on Tuesday I don't take my pills, and on Thursday I have my procedure. They also document that in the chart. So now every clinician knows what the plan is for the patient, so that in step 5, when the patient shows up for their endoscopy, everyone knows, hey, did you take your pill on Monday and stop it on Tuesday? It's right there documented in the chart. It's transparent and easy for everyone to see. To do that, we built a best practice advisory alert in our Epic EMR system. This is an example of what it might look like. And a couple key design features we built in here. This is automated, so as soon as you order the GI endoscopy, it runs a check on the med list and pops up if you take any anticoagulant or non-aspirin antithrombotic, something like clopidogrel, prasugrel, or ticagrelor. It's minimal workflow disruption for the clinicians. It just pops up right away. And it has an opt-out feature. So it's pre-selected to order the referral to the anticoagulation clinic. So the easiest thing to do is simply click accept and refer the patient. If the clinician says, no, I don't want them to go, they can do that, but they have to click do not order. They then have to tell us why they're not ordering and accept that. So 3 clicks, a little bit more work. It's just easier for the clinicians to go ahead and refer. And of course, once they've done that once or twice, they realize how easy it is to let the pharmacist do all the coordination and all the education. So there's a real incentive for our clinicians to do this. We wanted to make the right thing to do, meaning use our pathway, the easy thing to do. So some of the data, we started looking at this in the fall of 2017. I showed you some of those baseline elements and outcomes data. After we implemented this more than a year later, we found that inappropriate medication management fell dramatically from 17% to 2%. Same-day cancellations also fell. Patient satisfaction went up and clinician satisfaction went up. In fact, when we look at sort of the overall number of cancellations within 24 hours of a scheduled procedure, that number dropped as well, with an estimated $250,000 of billing revenue that we were able to recoup and not lose due to canceled procedures. So we really think this was effective, not just around patient care, but also had a strong financial model behind it that justified us actually hiring additional pharmacists to do this work. We've been able to actually see this be really effective during our run-in pilot phase. On the left side of the screen, you can see we had pretty good adoption. And then as that continued throughout 2018, and we actually now have data all the way up until the COVID pandemic showing really consistent, 2/3 to 3/4 of the time, people are referring patients to this when they get these BPAs. And in fact, on the right side, you see the clinician attitudes have changed dramatically. We have far fewer people saying that my institution needs to provide more help, and more people saying, yes, they have structures in place that help me actually manage these patients in the peri-procedural period. So I think we've made some really strong improvements in how care is delivered that benefits both our clinicians and our patients. Okay, I'm going to move now to the second story I want to tell you. This is the story about broadening the traditional role of the anticoagulation clinic. Now, many of you, I think, are familiar with anticoagulation clinics, or what for many years were called Coumadin clinics, because they essentially were there to manage warfarin or Coumadin. We realized that it was much better to have a team of nurses or pharmacists manage INRs and then dose changes in warfarin than it was to leave it up to individual physicians to do, because those nurses and pharmacists would follow some set protocols and provide better care. It was also easier for patients to be in touch. Yet these nurses and pharmacists really have a breadth and a depth of expertise in anticoagulation drugs and anticoagulation management that could be used to improve patient care beyond simply adjusting warfarin doses. For instance, they could help assist with drug or dose selection. Should this patient be on warfarin or one of the direct oral anticoagulants, and at what dose? There are lots of things they can do to help minimize bleeding risk. We talked about the peri-procedural period. There's also issues with combining anticoagulants and antiplatelets together. And of course, monitoring labs to make sure that there aren't issues with renal function, liver function, and the like. And of course, encouraging medication adherence by checking in with patient is a really important element of what happens in these anticoagulation clinics. I want to tell you a story about this multiple antithrombotic medication issue, because this is one we decided to focus on a few years ago. We know from a lot of data that if you take a single antithrombotic, be it an anticoagulant or an antiplatelet, you have some somewhat similar risk, a little debatable as to whether warfarin and the direct oral anticoagulants are higher bleeding risk than the antiplatelet drugs. But as soon as you start to combine those, that's where the risk of bleeding goes up, especially for patients who are taking 2 and 3 antithrombotic agents, which you see on the lower half of this graph here. And so those are the patients we felt like we could try and identify and do something to reduce their risk of bleeding. Now, interestingly, at the same time, we also had this series of large randomized trials coming out, really calling into question the efficacy of aspirin being used for primary cardiovascular prevention. For so long, I think we as cardiologists in the lay press talked about aspirin, prevent a heart attack, prevent a stroke. Yet with lower rates of smoking, better control of hypertension, and better use of statins, we're seeing that aspirin as a primary prevention agent maybe isn't as beneficial as we once thought. And in some cases, such as in the Esprit trial, could suggest there's even a bit of harm as compared to placebo. So we decided to look at that in our cohort of patients who were already taking an anticoagulant, meaning warfarin. So these were patients taking warfarin for AFib or venous thromboembolism who we were following for at least 3 months or more. Now, we excluded patients who had a mechanical valve or bioprosthetic valve replacement, or any of those who had a recent MI, sort of the common reasons where aspirin, in addition to an anticoagulant, may be indicated. So then we were left with this group of people for whom we didn't really think there was any strong need for them to be on aspirin while also being on warfarin. And we looked to see whether they were getting aspirin or not. And interestingly, about 1/3 of patients were taking aspirin. And that was pretty consistent over the study period, 2010 all the way through 2016. Really common that this was a case, this inappropriate aspirin use. Now, thankfully, the vast majority of these were using the baby aspirin dose, aspirin 81 milligrams. And of course, we're going to learn a little bit more about 81 versus 325 at the upcoming ACC meeting when the adaptable study is reported. But we said there's clearly a gap. There's an opportunity for us to improve care here. That was especially true because we knew that when you combined warfarin with aspirin, as seen here in the dark blue line, these patients had higher rates of major bleeding on the left and hospitalization for bleeding on the right than the patients who were just on warfarin monotherapy alone. And again, remember, these are the patients for whom we did not have a clear indication for aspirin. So we excluded the valve and the MI patients and all of the like. At the same time, we saw no difference in the thromboembolic events. So no difference in MI rates or stroke or other things like that. So we said, wow, warfarin plus aspirin, harm without any potential benefit, similar to what we had seen in the bridge study. So we decided to go about reducing this. And in this case, we used a 6 health center collaborative that we're a part of, the Michigan Anticoagulation Quality Improvement Initiative. This is a group that's actually sponsored by Blue Cross Blue Shield of Michigan, our largest funder in the state. And we include academic and non-academic centers with anticoagulation clinics that have both nurses and pharmacists. Some of us are phone-based system, whereas others see patients face-to-face. Some of us are in more integrated healthcare systems, while others are much more traditional health systems. So quite a bit of diversity here. And our goal was to identify the patient who had inappropriate aspirin use, to contact the provider for that patient, whether it's a physician, nurse practitioner, or the like, with some sort of a templated note, and then to help them with aspirin deprescribing if they felt it was appropriate. And what we found is that this aspirin use, while it was slowly declining over the course of time, really fell off once we implemented these processes. So you can see each of the 6 centers implemented this over the course of about 3 to 6 months, and this rapid decline in aspirin use during that time. Now, on the right side of the screen where there's the table, you can also see the adverse outcomes. So bleeding rates dropped significantly. We went from 26 down to 17 rates per 100 person years. The major bleeding rates were also slightly lower, as were the clinically relevant non-major bleeds. And again, thankfully, we saw no difference in the thrombotic rates between the patients before and after the intervention. Now, the question obviously is that's great for warfarin, but most people are now being started on a direct oral anticoagulant. Do we see the same pattern? And there's some data from my colleague, Jordan Schaefer, looking at this that's going to be coming out very soon in JAMA Internal Medicine, showing essentially the same findings. So on the left side of the screen, you can see the bleeding outcomes for DOAC alone in blue, or DOAC plus aspirin in the sort of the yellow, or what we would call maize here at Michigan, right? Showing higher rates of bleeding, both new bleeding and non-major bleeding, and ER visits for bleeding in those patients. While the thrombotic outcomes seem to be pretty similar for most patients in these cohorts. So again, probably the same pattern where you combine any oral anticoagulant with aspirin, you're going to have more bleeding. And if there's not a clear indication, there's probably not a lot of benefit. So our next steps really are to think about, well, how do we sustain this process long term? How do we make sure that the work being done by our anticoagulation clinic continues year over year? And how do we think about expanding that to patients who are on direct oral anticoagulants, patients not traditionally seen in the anticoagulation clinic? And of course, then there's the question, well, what about patients with a history of coronary disease, but maybe that coronary disease episode was more than a year ago, sort of the stable coronary disease patient? Is it reasonable to think about deprescribing aspirin in them? And that's certainly been endorsed by some of the more recent guidelines and expert consensus documents. So could we include those in our processes? And then, of course, what do you do when the clinician says, no, this person really does need to be on an anticoagulant plus an antiplatelet? Is there an opportunity to reduce their bleeding risk through other measures? Maybe putting them on a proton pump inhibitor to try and reduce upper GI bleeding risk. So these are all the things we're thinking about studying and implementing right now. Okay, so for the last few minutes here, I want to turn to our third story. This is a story I call working smarter, not harder. This is actually a phrase that I coined from a good friend of mine, Arthur Allen, who's a pharmacist in the VA system out in Salt Lake City. And he and I were talking one day, and we were talking about how with warfarin patients, they all get sent to the anticoagulation clinic, and we manage them one-on-one. We manually review the case for every individual patient. Yet for a direct oral anticoagulant patient, that same model doesn't exist. But if we try to force them into that model, it feels like we're working really hard. And he said, gosh, we have these great EHR tools. Is there a way we could work smarter rather than just working harder to try and support patients on direct oral anticoagulants? And I think that's a really great insight because we know that direct oral anticoagulants are not the easiest medications to manage. Yes, they were billed as being easier than warfarin, and there are many features that make them more convenient, right? Fixed dosing, no need for frequent lab draws or food interactions and the like. However, the dosing regimens are actually somewhat complicated. And in fact, frequently patients are prescribed inappropriate doses. You can see here on the left from the Orbit AF registry, this is a large national registry in the US, that about 13% of patients are receiving inappropriate direct oral anticoagulant doses, either underdosing or overdosing based on the package label. And when that happens, these patients have worse events. They have more major bleeding, more stroke and systemic embolism events. They're more likely to be hospitalized, and they have higher all-cause mortality. We looked at that at our Mackey collaborative. Again, 4 of the 6 centers in this statewide collaborative in Michigan are collecting data on direct oral anticoagulants, and we found about a 9.5% inappropriate drug rate, most commonly because of renal function or the apixaban dosing criteria. That was about half or so, but also liver dysfunction. Many people don't remember that if you have advanced liver disease, many of these drugs are contraindicated. And frequently, these were patients who were actually getting dosing based on the wrong indication. Maybe they were being given an AFib dosing when they really needed VTE dosing or vice versa. And so we said, could we use a population health approach to try and solve this? Could we pair a pharmacist or nurse in the anticoagulation clinic with a smart electronic health record tool so that the computer could now scan the entire health system to identify all the patients who are taking direct oral anticoagulants and then pull out the ones where there's potential dosing problems? So rather than having to scan the charts of literally thousands of patients, you can scan the charts just for the few where the computer says, I think there might be a problem here. It makes the pharmacist or the nurse far more effective and efficient in what they're doing, but also would allow them to expand their scope and their reach across a much broader population of patients. We actually started a little bit of this idea in a pilot. And we said, okay, within our QI registry, let's pull some patients and see whether or not we could make a difference. So we looked at about 550 or so patients, and we found about 11% of them had potentially inappropriate DOAC use. So that's pretty similar to our overall cohort and what was reported in the Orbit AF registry I showed you a few slides ago. Now, because of the way we collect data, sometimes the data is collected weeks or even a month after the patient was initially seen. And so there may be a timeliness issue here. But once we collected the data and said there may be inappropriate DOAC use, then one of the leading physicians or pharmacists at each center was contacted. And that happened about 72% of the time. They reviewed the chart and decided, should I go ahead and contact the ordering clinician? Or is this a situation where things have passed, or maybe it's a borderline case? Now, more than half the time they said, yeah, I'm going to go ahead and contact the clinician. And when they did, when they actually contacted the clinician and said, I think there might be a problem with the DOAC or the DOAC dose, about 2/3 of the time, the clinician said, wow, thank you for alerting me. I'll make a change. 1/3 of the time, they said, I have a pretty good reason for this, and that's okay. Yet overall, because we were using this research infrastructure, we only had impact on about 1/4 of all the patients. Yet we know that once we contact them, clinicians are highly likely to make a change. So we said, how do we operationalize this in real time rather than using a more delayed research infrastructure? And this is where something that we're calling the DOAC dashboard comes into place. And our goal is to build this dashboard for really any center that's using Epic, and perhaps in the future, any center using any of the major electronic health records. This is what it sort of looks like. And I'm for some silly reasons, I'm not allowed to show you the actual screenshot of it, but this is sort of a mock-up. What we are able to do within our dashboard is identify every patient who's taking a direct oral anticoagulant who we think our health system's in charge of managing. We can then filter those by which patients have flags for potentially inappropriate drug use. And in fact, we actually have different levels of flags, which flags are critical versus which flags are less critical but need to be alerted versus which are more FYI. And we can even break them down by the type of flag. Is this a flag because of drug-drug interaction, or because of renal function, or because of indication for dosing, things like that? And when you click on a flag, you'll get a list of patients with key information. They'll tell you who the patient is, what some of their demographics are, what drug they're on, and why they're on it. And it'll highlight if they think there's a problem there. Hey, I think the problem here is there's a drug-drug interaction with rifampin, or this person's getting apixaban 10 milligrams twice a day, but really they've gone beyond the point at which that's appropriate, and they should be dropped down to 5 milligrams twice a day, something like that. And so through this, you can quickly see what the potential problems are and then click into a patient's chart to make a change or contact somebody. So it's a highly actionable, very user-friendly design. Now, our plans, and this is work being supported both by Blue Cross Blue Shield of Michigan and AHRQ through a grant we've received, is to understand how well this works. Now, I'd love to say that we thought of this on our own, but that's not true. This is actually a tool that was developed by the VA. So I mentioned Arthur Allen, that pharmacist in the VA. He and a close colleague of his, Patrick Spouts, both pharmacists, Patrick is also a programmer there, thought about this idea and said, could we build this leveraging the VA's national data set? So they actually did, and they were able to build this tool and roll it out over the national VA system a couple years ago. So the first step we're doing is going to analyze how effective this was. What are the implementation outcomes of this particular tool being rolled out? So we look at things like reach. How far did this get? How effective was this? Do the centers that use this tool have lower rates of bleeding and stroke and the like? How well was this adopted and over what time course? Let's look at the number of sites nationally. Talk a little bit about the implementation process and what we see, and of course, how well this is maintained. Once a site uses it, do they continue to use it? Or do they dabble in it and then just let it go away? So trying to learn as much as we can there. We've actually completed now a bunch of interviews with frontline clinicians at VA sites. So we've looked at a number of sites to ask them what their experience was like, what challenges they had using this. And we also went to our Mackey sites. These are the sites, non-VA sites in Michigan, and said, hey, we're building this tool. What are some of your anticipated challenges? So from the VA, we got the realized challenges, and the non-VA, we're going to get the anticipated challenges, concerns, barriers, and the like. And from that, we've developed an implementation plan or set of strategies we're going to use to try and roll this out across 4 different centers in Michigan and use our QI infrastructure to collect data and see how effective this is. So these are the plans. This is some of the work we're doing right now, but we think this idea of population health approaches to managing the anticoagulants may be a way to really broaden the reach of the anticoagulation clinic and have really great impact. Now, not just dealing with dosing, but as we mentioned before, what about inappropriate aspirin use? Could that be the next phase of this? What about perioperative management? Could we find ways to flag when a person's been scheduled for a surgical procedure and then allow our pharmacists to quickly intervene and help with some of that? So you can see how this now becomes a platform for leveraging the skill set and the expertise in the anticoagulation clinic to make anticoagulation care safer and more effective for patients across a wide range of modalities. So in summary, I've told you about 3 different stories. Our first story was one of redesigning care delivery, where we really spent a lot of time understanding how current pre-endoscopy care was being delivered, taking a team-based approach to redesigning that care delivery with the patient as the center feature of that. And then our eventual intervention was really centered on this idea of making the right choice the easy choice. So that way clinicians were likely to fall in line and use our new process. Secondly, we took the idea of expanding the role of the anticoagulation clinic beyond simply checking INR results and adjusting warfarin dosing to saying, what else can we do to make anticoagulation care safer? And can actually our nurses and pharmacists help with deprescribing unnecessary high-risk medications? The next step obviously is going to be when that's not the case, can they actually help initiate other meds that are used to reduce bleeding risks, such as PPIs? And so that's work that's ongoing right now. And then the third is our work smarter, not harder story, where how do we leverage these electronic health record tools that are now essentially ubiquitous across most health systems? How do we bring expertise from pharmacists or nurses to all patients, not just those that are being referred into the clinic, but really thinking about owning the patients across our health system to make sure that they're getting safe and effective care, and that we're supporting our patients and our clinicians more broadly. Now, I want to acknowledge a whole host of collaborators and mentors that have helped me with many of these projects. And you see many of the names here, and I'm really indebted to so many of them for helping me guide through this process, both during my time in training and these first few years on faculty. I'm really grateful to the 3 pharmacists who I work closely with in our anticoagulation clinic, who are just an amazing resource and always willing to participate in these ideas, to some of my research team and the team that specifically is being funded by Blue Cross Blue Shield of Michigan and the Mackey Collaborative, as well as both the NIH and AHRQ, who fund some of this work. So with that, I'll thank you all for joining today. I've really enjoyed getting to share with you some of the work we're doing. I'd love to connect with any of you on Twitter. You can see my handle there, and I look forward to any Q&A. So to Dr. Cooke, thanks again for inviting me. I look forward to speaking with the fellows later today, and I'd be happy to take any questions that folks have.
Jeff, congratulations on a spectacular presentation and such thoughtful, meticulous work to improve our management of patients on anticoagulation in a systematic way, really a population health approach. Really spectacular work. One of the things I was struck by is your hypothesis generating hypothesis-directed approach, and clearly, you've been very successful at raising money for your research through the National Heart, Lung, Blood Institute and Agency for Healthcare Research and Quality and Blue Cross Blue Shield. Can you? We have junior faculty that are listening in and are trying to get their career going. Funding is the fuel for that. Tell us, do you have any advice for those faculty in terms of how to be successful at raising money to support your clinical research?
Yeah, I think that's a really great question. And, there's always an element of luck that's built in, and I'm extremely fortunate that I've had that luck with the work I'm doing. But I also think there's ways to position yourself. And the first thing I would say is mentorship is critical. And I am extremely grateful to the many mentors who sort of helped get me there. One of my first mentors, Jim Freilich, who's the head of our anticoagulation clinic and is a national leader in the vascular medicine space, really helped to position me to make some of those connections. And he and I worked together with Blue Cross Blue Shield of Michigan to get our Mackey collaborative, our multi-center QI collaborative started. And that's been the foundation for a lot of the work that we've done. And then beyond that, I reached out to other mentors who had really specific research expertise. One in particular, Ann Sales, is an international expert in implementation science. And she's really helped to guide me as I think about how to ask these questions and how to approach these projects in a methodologically rigorous way. And so I think mentorship has been key. The other 2 things that I've learned from my mentors are making sure you identify and clearly articulate the problem and the scope of the problem, why it's a significant thing people should be invested in, but then also that you're approaching it with as much evidence as possible. So how are you using well-designed frameworks and well-designed approaches? You're not simply shooting from the hip, but you're really doing your background work and your homework to understand why your intervention has evidence behind it that's going to make it most likely to be effective. And for me, that combination of things, I think, has been really instrumental in having some success.
Thanks. I hope you can continue that conversation with our fellows later today, because they're also going to be very interested to get your advice. But there's some questions coming in from the audience, and one question, interesting one. Tell us about medical legal issues that you might have encountered with anticoagulation clinic that's operating system-wide.
Yeah, that's a really great question. We've actually spent a lot of time thinking through some of those elements. And so there's a few different layers that we put in place to protect. So the first is that when our nurses or pharmacists are working, they're always doing so under a very clear institutional protocol. And those protocols are vetted and approved, not just within the anticoagulation clinic, but also by our anticoagulation pharmacy and therapeutics committee, and that's signed off on. So for instance, when we looked at the aspirin deprescribing project, or we look at the endoscopy project, we put in very clear protocols about how they should operate so that they were institutionally supported. The other thing is that all of the pharmacists and nurses work under the direction of a physician or NP or PA. And so we have to make sure that there's a clear line of communication there. That's why if you noticed in the perioperative project, the first story I told you, there's actually a referral that the clinician has to sign and send that referral to the anticoagulation clinic. Thereby, the ordering clinician, maybe it's a primary care doc, is actually delegating their authority to the pharmacist in the anticoagulation clinic to help use institutional protocols to guide the decision making. So the pharmacists aren't doing this on their own. They've been delegated that authority by the physician. They're using institutional protocols, and then they always check back. So we always have them send a note back to the physician to say, here's the plan that I'm going to recommend. Let me know if you disagree. And so that way we have sort of those checks and balances in place so that the pharmacists or nurses are not doing something beyond their scope, but it's very much within the structures that have been put in place for them.
That's great, Jeff. I think you already answered the second question, and that is, how do you obtain physician buy-in to this anticoagulant clinic? You've kind of addressed that, but do you have have you had any instances where you didn't get buy-in? How did you deal with that? How do you confront that problem?
Yeah, that's a really great question. So thinking back to the first story, the GI endoscopy story, it's interesting. We felt like there was a problem early on. I was working with a colleague of mine who's actually a GI endoscopist, and we went to the head of the endoscopy unit, the physician director. And the first response she said to us was, "We don't have a problem. We manage this fine." So then we brought some data to her and said, hey, here's how often we're having issues with canceled procedures. And she said, no, we know what to do. We have our guidelines. We're okay. So then we went and talked to the other docs and we said, hey, is this a problem? Tell us. And we got that qualitative data. So I had the mix of sort of how frequently they were having canceled procedures and the quotes from her colleagues saying, this is confusing. I don't know what to do. I need help. And that third time, it was when she said, oh yeah, this is a major problem. You could help us with that? That's great. So coming back, understanding the pain points and really presenting that with data and personal anecdotes, I think was really helpful.
That's interesting. So you use data, but there's an emotional component to getting physicians comfortable with this. That's so interesting.
Yeah, I think it's the storytelling, right? It's telling the story of a person or a patient in addition to sort of the raw numbers, and that combination is often what can be effective for people.
Yeah. You mentioned that you have you provide an advisory role to several companies, and so you have your ear to the ground. What can you tell us about what's coming next in anticoagulation or in monitoring of anticoagulation? What's going to be the next big development?
Yeah, I think that's a really great question. And obviously predicting the future is always hard. I know that right now there's a lot of effort being focused on awareness. You know, most of us know that we use these anticoagulants for AFib and venous thromboembolism. But a lot of work is being done on the implementation, the systems. How do you use this to maybe avoid hospitalization in a VTE patient who's fairly low risk? Rather than admitting them to the hospital, could you put a system in place using the anticoagulants to manage in the outpatient setting? There's, of course, a whole host of expanded indications. I'm thinking in particular about peripheral artery disease. We now have an FDA-approved indication for low-dose, very low-dose rivaroxaban. Awareness of that, thinking about when it's appropriate and when it's not, there's a lot of work being done there. Looking out a little bit farther, there's a whole nother class of anticoagulants that are being developed and tested. And so whether or not they're going to show efficacy and where their sort of niche areas are going to be, I think that's something to keep your eye on over maybe the next decade, but probably not in the next year or two. I think they're still a little farther away. But clearly there's a lot of exciting work to be done in this space.
Clearly, I mean, you're establishing better communication with the patient and the physician and monitoring the patient. What about, is there any application for wearable monitors? Are there new wearable monitors coming down the pike that could help us with anticoagulation management?
Yeah, that's a really interesting question. I'm not sure that there's wearables to help with the anticoagulation management, but where I do think there's two really key elements. First is in detection. We're seeing a lot of these wearables help with AFib detection. And of course, once you detect AFib, then you have to decide whether or not to treat it. So that's a really interesting and exciting area that's emerging. There have also been some really interesting studies, many of them out of Asia, looking at how we can use tech-based tools, whether it's apps on the phone or the computer, to help with decision-making around anticoagulation and to help people remember to take their anticoagulants. We know that frequently patients started on an anticoagulant will stop for one reason or another, and can we use some of these tech tools to help patients with persistence issues and adherence issues so that they really get the maximal benefit of the drug. So I think that's two areas where technology interventions are going to be exciting in this space.
Well, Jeff, we've come to the end of the hour, and but you've left a lot for us to consider, and I look forward to continuing our dialogue as time goes on. Jeff, thanks so much for the presentation today. It was just spectacular.
Thank you so much for having me. It was my pleasure.
Dr. Geoff Barnes, everyone, assistant professor at the Frankel Cardiovascular Center at University of Michigan, leader in antithrombotic management, providing us some wonderful data today, wonderful information. Thanks so much.